I'm Brian France. I'll be the moderator today. I thought that the title for the presentation was very clever. I'm sure most of you know that the story behind the oracles of Delphi. It was a very famous place in ancient Greece where the priestess Pythia would deliver these prophecies, and people from all over the world would go there to hear these prophecies about the future. Very similar to how we have people from all over the world here at this meeting to hear our two famous oracles prophesize about the topic of prognosis today. So I think it was a very clever title. I had to do a little bit of research too to know all of that. So don't feel bad if you didn't know the whole story. Our speakers today are obviously extraordinarily qualified to discuss this topic. They're outstanding educators, clinicians. They've both won the Master Clinician Award. They've won, I think, every award there is to win, or they have been awarded and earned every award there is to gain in the academy. And so they're very well qualified. They're very inspirational. And as I said, excellent clinicians. What they're going to talk about today is the historical context, the rationale, the relevancy, the validity, and maybe some future insights for us in terms of prognosis. On a personal note, both of these individuals really inspired me as a young periodontist in so many ways, and they both have had a profound impact on my career. And so I really want to take the opportunity to thank both Mike and Jack for what they did for me in my career. So with that said, our first speaker today is Jack Caton. Jack is by the way, if I had to read their CVs, there would be no time for the lecture. So Jack is currently the professor of dentistry and former chair of the Department of Periodontics at Eastman Institute for Oral Health in Rochester. He is former chairman of the American Board of Periodontology, past president of the American Academy of Periodontology, as well as past president of the American Academy of Periodontology Foundation. He received his DDS from the University of California Dental School in San Francisco, an MS from the University of Rochester, and Periodontal Specialty Certificate from the Eastman Institute for Oral Health. He's published over 130 scientific articles, book chapters. He's received the Gold Medal, Master Clinician, Distinguished Educator, and Service Awards from the Academy, and also the William Guise Award for contributions to periodontal literature, as well as the Norton Ross Award for excellence in clinical research. So it's my pleasure to introduce Jack Caton.
Thank you. So I figured a couple of years ago it'd be the last time that I was going to ever give a lecture at the Academy. And when I was invited to speak with Mike, who's been a friend of mine forever, and Brian, who's like a son to me, I just couldn't resist it. And so I'm very happy to be here. I'm very happy someone showed up. I mean, the subject of prognosis is not the most exciting thing. There's no incisions, there's no blood, no bone grafting or anything like that. So, but, if you practice periodontology, it's something you have to do for every patient that comes in while you're treatment planning, reevaluating, retreatment planning, which the practice of periodontics is a never-ending deal in terms of reprognosticating and retreating. So I think it's an important subject, and it was very important to me as a young periodontist. This is going to be a very short and simple talk. We only have 45 minutes to begin with, so you can't really go into detail, but I don't even think that makes the difference. It's kind of a natural thing for periodontists. After you've been in practice a while, I was privileged to be in private practice for 50 years. I'm not sure at the end there the patients were so privileged, but I finally had to quit. Every time I drank a cup of coffee, I couldn't hardly hold a fork anymore. My hand was shaking so much. And that really is not a way to sell yourself to, a new patient. And so what we're going to talk about is, first of all, how the Kwok and Caton system developed. Secondly, what is the Kwok and Caton prognosis system? A simple explanation. And then what I think are the advantages of the system. I don't feel that this is a deal between Mike and I who has the best prognosis system. In fact, I defer to Mike. Mike knows more about prognosis than I'll ever know. He did studies probably starting in the late 80s in his practice where he identified determining factors that might be important, and then did a longitudinal study to follow those patients for 8 years or more. And not only that, he published 4 papers starting in '91, and a lot of you weren't even born at that time probably, and then finished up in 1999, all while having a very busy practice, a busy professional life. And so kudos to Mike, and it's probably one of the reasons why there is the interest in, especially from this country, the interest in prognosis that exists today. So I don't think that you have to decide which is the best system to use. I'll conclude and say, of course, it's my system, but it's not really. I'm just kidding, actually. We both use the same principles, in fact, and that you'll see at the end of this thing. So I was privileged as a young periodontist. My mentor was Helmut Zander. He was an old German professor that escaped the Germany, in the early 1930s, I think, and wound up coming to the United States. He knew everyone. So I started my residency in 1970 after 3 years in the Army, and we had people visiting us. Jens Verhoeg used to come twice a year, Jan Linde, Harold Lowe, and all the names that you have read about. And I got to meet in person, go to their seminars when they would come. And then I had a year with Stura Niemann, who, if you don't know who Stura was, he was a fabulous clinician and a very stubborn guy. And he, was also developed as a periodontist in the same atmosphere with, Per Axelson and Jan Linde and Rosling and all these famous guys. And the single thing that they did was control bacterial plaque in terms of maximizing the results of therapy, but also prevention of treatment and prevention of disease. It was plaque, plaque, plaque. And at the same time, had others that, like Carranza and Irving Glickman, and that crowd that were pushing, occlusion, occlusion, occlusion. So I feel that when I was developing my feeling about perio, that bacterial plaque was all important, and if you could control that over the long run, you could have a successful periodontal practice, and that's what I was trying to emphasize to my residents, that we should be positive about going forward. And so I didn't write it down. We just practiced this system that was published in 2007. I didn't want to publish it even. In fact, Dr. Kwok, who was a former resident of mine and now a fellow faculty member, convinced me to to publish it. I didn't do any research on it, and I would only publish it as an opinion. And it was a fairly long paper, but it was an opinion. So as a result of this contact with all these famous periodontists and all of the research that was coming out on the role of bacterial plaque, I felt we really need to emphasize this aspect of therapy. At the same time, there were several issues relating to occlusion, and I felt that the role of occlusion in the etiology and progression of periodontitis was now de-emphasized, not eliminated by any means, but de-emphasized, so that and I agreed with that, even though that's not the way I was trained. So this was due to, I think, starting off with Jan Sverhog, and then Jan Linde and his studies in beagle dogs, and Alan Poulsen and his studies in monkeys, Sean Meitner, other students of Alan. Now, that was my program, so I was right in the middle of this battle between Linde and Poulsen about, should we use a dog or should we use a monkey? And I didn't think it was that important in animal studies, but they came across with many, many very important principles. And while some of Jan's studies indicated that you could affect the progression of the disease if you had trauma from occlusion and plaque-infected dentition, Poulsen didn't come up with that in monkeys. Well, where it lies right now, I don't even know for sure. We still have a lot of mysteries about occlusion. So I trained my residents to emphasize plaque and de-emphasize occlusion. And in terms of etiology and maintenance therapy. And so when we wanted to, actually, Vivian Kwok made me put this down on paper, so we wrote the paper together. And as you can see from the diagram, we were presuming that you would have adequate maintenance and daily plaque control. That was the presumption. And then we could make predictions relative to other factors, we called them determining factors, that Mike outlined so well in his papers, and others have done in Europe, in terms of what's important relative to determining prognosis. So we never were sure, we can't be sure of our prediction or our prognosis, so we put terms like favorable, meaning it's likely, questionable, and unfavorable, maybe, unlikely. In other words, we couldn't say with certainty. There was not enough data for us to be able to, and there still isn't, by the way. And so the difference was that we based this on our ability to stabilize the periodontal supporting tissues. We didn't base it on tooth loss. I felt tooth loss was a very negative way of approaching patient management. And I was training clinicians, firstly, sometimes researchers and academicians too, but not usually. We're training clinicians to go out and do right by their patients. And I wanted them to have a very positive attitude towards predicting the future, as long as they emphasized personal plaque control and periodontal supportive therapy. So, in essence, it's just a simple system. We either have favorable, questionable, and unfavorable. Hopeless, well, it's too late to even, I don't have to tell you what hopeless is. This is a tooth that's coming in, hanging by a couple of threads. So favorable means that we're going to most likely be able to stabilize the supporting tissues. And questionable means we don't really know for sure. It depends on the results of our therapy and controlling factors, whether they're patient-related factors or other factors that are not under the patient's control. And then unfavorable means that we're probably not going to be able, unlikely we'll be able to stabilize. And that's it. That's the essence of the system. And so it's worked well in our program. It's been tested by others in other programs. They're not prospective, retrospective studies, and it's shown to be reasonably accurate up until about 5-6 years, right? Mike's studies show a lot of the same. So the important thing now in the future is the determining factors other than plaque control. And so while that may still be the overwhelming factor, there are other factors that we have to take into consideration, and these are all published. Systemic factors such as uncontrolled diabetes, maybe other problems, genetic factor, IL-1 positive genotype, environmental factors such as smoking and other nasty habits. Drinking too much Jack Daniels maybe is not good for you either anymore. Some years it's good, some bad. Bone loss over age, which gives you an idea of the speed of the disease, susceptibility of that individual patient. Bleeding on probing, which gives you the overall kind of state of infection of the dentition. Pocket depth, which is greater than 5 millimeters, harbors periodontopathic bacteria, and certainly plaque retentive factors. And I certainly want to give credit not only to Mike for a lot of these factors, but also to Klaus Lang and Maurizio Tonetti, and then others since that time to refine the periodontal risk assessment, which I encourage, if you haven't read it lately, to go back and reread it. These people really, I think, know what they're doing, in fact. So what have we found about this system? Why did we publish it? I'm not 100% sure why we published it. Actually, Vivian made me publish it. But it's the same with any other system. As new information is added to determining factors, and technology being able to analyze in seconds maybe some biological factors in the gingival fluid, which would put patients at risk. That system can evolve very easily. Next is the fact that modern computing will assign importance of the individual determining factors. For instance, if say personal plaque control or periodontal supportive therapy is 8/10 of the battle, what are the other factors? What bleeding and bone loss versus age and all these other factors, diabetes, smoking, and so forth, they have a value in determining the risk for further disease progression. And modern computing will develop algorithms, and are developing these algorithms, to provide personal prediction for that particular patient in your office. And I think that's going to be something that you're going to put in, like we do, the marvelous, automatic probing to develop, so you don't have to write down every probing depth that's done by computer. It's going to be an algorithm that you can use to personalize the prediction for not only that particular patient, but individual teeth in that patient's mouth. And then finally, I think that this system emphasizes positive outcomes for both patients and clinicians. And I think that's the attitude that I want my patients to have, which I want my residents to have. And so that's it. It's a simple system. And we hope we have time for questions if you have any after the presentation's completed. Thank you.
Thank you, Jack. Our next speaker is Dr. Michael McGuire. Dr. McGuire is the author of over 85 peer-reviewed and published scientific manuscripts, an unparalleled amount of work for someone who's in full-time private practice. He is also the founder and the chair of the McGuire Institute, a nationwide not-for-profit practice-based clinical research network. His research has received the American Academy of Periodontology's highest recognition for excellence 4 times, earning the Robinson Regeneration Award and twice the Clinical Research Award. He is also the recipient of the Academy's prestigious Master Clinician Award and the Academy's highest honor, the Gold Medal Award. And in 2015, he received the William J. Guy's Periodontology Award for his distinguished achievements in perio. Dr. McGuire is past chairman of the American Board of Periodontology. He has served as president of numerous dental organizations, including the American Academy of Periodontology and its foundation. He is a voting member of the FDA Dental Products Devices Panel. Dr. McGuire received his bachelor's degree in psychology from Baylor. He earned both his DDS and Certificate of Periodontics from the Emory University School of Dentistry. And in 2009, Emory University recognized Dr. McGuire with their Distinguished Alumnus Award. So it's my pleasure to introduce my friend, Mike McGuire.
Thank you, Brian, for the nice introduction. Thank you to the organizing committee for the invitation, and especially thank you to everybody for attending today. You know, it's been 35 years since I started this. I mean, I couldn't believe it myself, you know, as I started preparing for this lecture. And I look at this lecture somewhat as hopefully beginning to complete the circle. We're not going to quite make it around, but we're going to try to begin that process. And what I'm going to do this morning is to give you some highlights of the 4 papers that we published. You know, Jack and I were talking a minute ago about this, and he said, you know, he had reread my papers, and I reread my papers, and frankly, I was impressed. I thought they were pretty forward-thinking from way back then. But we're going to talk a little bit about some of the major conclusions of the papers, because a lot of you probably know the classification system, but I doubt many of you remember, maybe even read the papers. And so I want to highlight a few conclusions. There's also some misconceptions about these papers, and I want to talk about these misconceptions a little bit, put them in historical context, because again, you have to put yourself back in the late 80s, early 90s. It was a different time as far as how we managed disease at that time. And I want to build the case for including risk factors and patient factors today to really build an effective prognosis. And I'm going to end with a little teaser on a study that we're doing now using AI to develop decision support systems, where really that's where the future lies. As far as conflicts, I have very few for this lecture. As Brian said, I'm founder and chairman of the McGuire Institute. It's a not-for-profit practice-based clinical research institute, and we have partnered with a leading AI company called Lightspun, and we're in the process of developing this decision support system. You know, this is a picture that was made of Jack when he and I were ascending the officer chain at the AEP. You know, he actually looks better today than he did back then. You know, it's amazing. And prognosis and prediction's difficult, evidently even for Nobel laureates, where Niels Bohr says prediction's very difficult, especially if it's about the future. And you know, it's interesting that as I began to prepare for this, I can remember the exact day that I began to think about prognosis. And prognostic factors are those characteristics that may predict the outcome once a disease is present, but they don't actually cause it. And Ken Kornman was nice enough to invite me to interact with his residents fairly frequently in San Antonio. And it was in the late 80s, and I had spent the afternoon with the residents, and I was driving back to Houston. It's about a 3-hour drive. And so I was thinking, you know, about the day and how it went. And one of the questions that I had from one of the residents was, Dr. McGuire, what do you think the prognosis of this case is going to be after the therapy? And it got me to thinking about, you know, what do we really know about prognosis? And as I got into it, I thought, you know, we don't really know a lot about prognosis. So that then led into a study that we began in the late 80s and finished in the early 90s, where what I did was I looked at 100 of my patients consecutively on maintenance that had moderate to severe periodontitis. All had been treated by me. And I wanted to see the initial prognosis that I assigned, and then we reassigned them at various times. Did that track? Did good remain good? Did good change? Those kind of things. And so we published over the years these papers. And it's interesting that the papers have been recognized over the years. I was honored that the first 3 papers won the AAP's Clinical Research Award, which is supposedly the most clinically relevant paper in periodontics for that year. And still they're recognized. In this review last year talking about they were seminal foundational papers where for the first time trying to put evidence into something that's up to that point had been purely subjective. But even though they've been recognized, and even though I'm kind of known for this stuff, this may surprise you, but this is the first time, the only time I have ever lectured on prognosis, ever. Jack alluded to that. This is, you know, I tend to lecture on what I like, what I find interesting. And for most of us, prognosis is a yawn. And so I'm not going to go around lecturing on this. So you're about to hear my first lecture in 35 years on prognosis. But it's interesting, as I travel and as I'm asked questions, because people frequently ask me questions about prognosis. Oftentimes it's a resident, and they want to know something about it. And as they're asking me these questions, I'm wondering, did they read the same papers I wrote? These papers have taken on a life of their own. And that's part of the reason why I don't lecture on them, because I don't want to get into all of this stuff. And so what has happened is people over the years have read these papers. They have lectured on these papers. They put their conclusions of what they think these papers said in their lectures. They've even written about these papers. And really, it's kind of created an urban myth that, you know, if you say something often enough, then people think that's a true statement. So I'm going to kind of set this record straight, and I'm going to actually go through some of the urban myths and also the major conclusions of the papers. So and I'm going to use some quotes and actually read so you don't think I'm rewriting history here. So in the first paper, and the first urban myth was that I set out to create the McGuire and Nunn system for prognosis. That's not the case at all. What I did was I looked at how we were taught to assign prognosis. And at that time, every periodontal textbook had the perfunctory chapter on how do you assign prognosis. And yes, we actually learned from textbooks back then. And so they suggested that we look at all the factors I have on the screen, these commonly taught clinical parameters, mainly tooth-related, and then some on host. And you're supposed to uniquely apply them to the individual in the tooth, and out pops the prognosis. If you looked at the literature back in the late 80s, there was basically nothing on prognosis. There were Beckerberg and Becker and Hirschfeld and Wassman mentioned prognosis, but it was related to more maintenance and that kind of thing, not really this subject. And so there really wasn't much out there on how you're going to do prognosis. So, you know, it wasn't I didn't do this to create our system. I did this to look at, is it these commonly taught clinical parameters, Are we effective? And, quote, the development of prognosis based primarily on anatomical factors is questionable in light of new understanding that periodontal diseases may occur and progress on more random basis depending on disease type and microbes rather than on factors as root proximities. These studies stress that periodontal diseases are site-specific infections that depend much more on pathogens and protected species and host resistance than they do on this prototypical list for prognosis. In conclusion, it was found that projections were ineffective in predicting any prognosis other than good, and that prognosis tend to be more accurate for single-rooted teeth than for multi-rooted teeth, and further information was needed. Another urban myth on this first paper is that it's a static system. I hear people talk about and read that this McGuire and Nunn system is a static system. That's not the case. Again, quote, following the active phase of periodontal therapy and prior to placing the patient on maintenance recall, each tooth was assigned to prognosis. Prognosis and tooth loss was also recorded at 5 and 8 years into maintenance care. The same set of criteria were used for assigning prognosis initially as were used at 5 and 8 years, and these assessments were blind to previously assigned prognoses. Prognosis development in this study utilizes all data collected at each recall interval at the 5 and 8 year interval. This method promoted a much more dynamic decision-making process mimicking that used in clinical practice, so it's not a static system. I even use the words dynamic decision-making process. Well, that led to the second paper. So basically in the first paper we found that if you used all of those factors, they were only good at predicting good prognosis, and that's pretty easy. So the second paper I said, okay, if we don't need all of those factors, are there certain factors we need to weigh more heavily? And the results of this study indicate that some clinical factors used in the assignment of prognosis are clearly associated with changes in condition over time. Data indicates that more weight should be placed on some of these factors. Smoking and diabetes double the likelihood of worsening in prognosis at 5 years. And in addition, studies needed to be conducted to determine which, if any, microbial or immunologic factors may also be important in the assignment of an accurate prognosis. So I'm beginning to build the case here back in the late 80s, early 90s that host is very important. We can't just look at tooth-related factors. Recently, interest in the subject of risk has increased. Although some models will allow us to evaluate risk on an epidemiologic sense, the real challenge lies in the development of a model that will predict outcome on an individual patient basis. And here, the epidemiologic thing, I'm talking about Lowe studies, and we'll talk about that in a second. Unfortunately, this work will be difficult because of the newer concept of periodontal diseases provides many more factors of uncertain influence that are difficult to measure and monitor. So again, put yourself historically, it was impossible to factor in this at that time. It's really difficult now. It may be with AI in the future finally able to factor all of this in, and we'll talk about that in a second. That brings us to the third paper and the third urban myth, and that is our system is based on tooth loss. Our system is not based on tooth loss. We had one paper on tooth loss, and why did I do that? At that time, to my knowledge, there were no papers published in periodontics that looked at survival analysis of teeth. Why? Because you have to have a large data set with lots of teeth to do survival analysis, and at that time, either they weren't available or nobody had done it, and also at that time, prior to that time, there were not statistical methods to be able to manage that. And so all of that came together. We had the opportunity to do that, and so we said, okay, why not? And in addition to that, we wanted to look at tooth loss because we thought it might eliminate some of the subjectivity. You know, when you assign prognosis, there is subjectivity in how you apply that to the particular patient and tooth, where, you know, a tooth is either there or it's not. However, we know that very few teeth just fall out. Ultimately, it's the dentist that decides when to take the tooth out. So there is subjectivity in that, but that's the background on this. And, quote, the results of this study reveal a distinct relationship between prognosis and tooth loss. Teeth with a worse prognosis have a worse survival rate. So if you look at the survival plot there and you see the different lines, that's good, fair, poor, questionable, and hopeless, you see all these lines have broad separation, which means that they are statistically significantly different. That's a big deal. The study clearly demonstrated that teeth classified as questionable or hopeless can be maintained for long periods of time, and that is the definition of achieving and maintaining stability. And then the final urban myth is the fact that it's really not the tooth loss. It's just the stability that this whole thing, all of these papers that we're looking at, all of our studies focused on the probability of maintaining stability of the assigned prognosis. the potential to control the disease and prevent further breakdown. And how did we determine stability? By periodic reprognostication, following treatment and throughout maintenance, allowing for comparison between the initial prognosis and subsequent assessment, actual outcomes. So the title of all of the studies was prognosis versus outcome. So we're always looking at outcome. And then that brings us to the final paper where we're looking at host exclusively. One of the underlying premises of this series of papers is that the traditional process for assigning prognosis was created on an outdated model of disease progression, which was based on the assumption that all plaque was the same and everybody's equal susceptible. In this study, we found a positive IL-1 genotype increased the risk of tooth loss by 2.7 times. If they were a heavy smoker, it increased the risk of tooth loss by 2.9 times. If they were a heavy smoker IL-1 positive, it was multiplicative and it increased the risk by 7.7 times. This study is the first longitudinal assessment of a specific genetic influence on the deleterious outcome of periodontal disease, and one of the first attempts to determine just how new genetic information is clinically relevant. Bacteria causes a disease, but it's the individual's genetic makeup and environmental influences, such as smoking, that will determine how severe the disease will be. Unfortunately, we don't have any generic patients. All of them are different. We know that bacteria is what initiates all the disease, but it's the genetic and the acquired risk factors that create the inflammation that then determine the final disease severity and progression. We know that we have some people, like this individual, like this lady, who even in the presence of severe plaque and calculus, lots of etiologic factors, she never will get beyond gingivitis. Unfortunately, we also have people like this young man who in his early 20s with no signs of plaque has severe disease. At some point, this guy was healthy and at high risk, but can we determine that before risk occurs? Having effective risk assessment tools are essential because individuals who are resistant cannot be distinguished from those at elevated risk before disease occurs. Health is indistinguishable from the initial disease state, which is preclinical. And risk does not equal extent and severity of disease. This is something that most dentists, periodontists don't really think about. We tend to think if we see an individual with a lot of disease, they're at high risk. If we see an individual with no disease or little disease, they're at low risk. That has nothing to do with it. Most clinicians apply the same treatment plan and preventive care to patients regardless of their risk profile. That's problematic for both patients and clinicians alike because somebody's going to be overtreated and somebody's going to be undertreated. Risk and diagnosis are entirely different entities. Patients with the same diagnoses may require different treatment plans based on their risk profile. This individual, if they're at low risk, may only require prophylaxis once a year. If they're at moderate risk, they may require quarterly periodontal maintenance visits. If they're high risk, they may require significant early intervention. But no matter which prognosis classification system you choose to use to be clinically useful, the development of prognosis must also include disease-modifying risk factors. Risk factors, as opposed to prognostic factors, are defined as those patient characteristics associated with the development and progression of the disease. Dr. Caton mentioned about the Pratt's periodontal risk assessment, and they've been out here for some time. Lang and Tonetti and then Roy Page did another one. They're developed mainly for general practitioners to help guide what type of maintenance programs patients should be on. And it's an attempt to bring in systemic risk, but there's issues with this. They have very low sensitivity and specificity. You can use both of these different systems on the same patient and get different answers. And I think one of the biggest problems is they depend heavily on past disease. So they're of no use to somebody who has yet to experience disease to determine at what risk are they. The Academy also realized that we needed to do something to change our disease classification system. And in 2017, the Academy held the World Workshop on Classification. Dr. Franz, Dr. Caton, myself, many of you in the audience were part of that. We created a much better disease classification system because we moved beyond simply describing the severity to incorporate complexity, rate, progression, and individual patient risk factors, trying to create a more personalized approach to this. But still, there's issues here in that the staging is analogous to a lot of the factors that we've been talking about, the tooth-related factors, but the grading cannot be applied to healthy subjects or to patients with gingivitis. So that's a real problem, again, if we're talking about risk. So can we determine which path our patient's traveling? If you look at all of the diseases of aging, cancer, Alzheimer's, osteoporosis, diabetes complications, heart disease, periodontitis, and you look at this line here, unfortunately, it's misleading. It's not a single line. They're really separate lines. You have some of our population that are going to start having problems with the diseases of aging in their 4th decade, and you have others that may not experience these until their 7th or 8th decade if they experience them at all. But the unique thing is all of these lines begin at the same point. They're healthy at some point. There are no biochemical or clinical changes. There may be some genetic changes, but what we need to be able to do is determine their risk. And that will allow us to personalize how we're going to manage these patients. We want to do it while they're healthy, so we can move that red line more toward the green line. But to do that, it has to be actionable information. We can't just have a bunch of factors, but we don't know what to do with them clinically. Well, does this apply to perio at all? Yeah. If you look at the Lowe study, where he looked over 15 years, or they looked over 15 years at Sri Lankan tea farmers. And they never saw a dentist. They didn't know what a toothbrush was. They had no social mores of cleaning their teeth. Again, this was back when plaque was plaque, all of it was bad, and disease depended solely on the amount of plaque. And so if you have a population like this, what did they find? They found they had 3 distinct groups. They found that 8% of these patients, or these tea workers, lost almost all of their teeth by age 40. They found that 11% never had much more than gingivitis. And they found that 81% looked pretty much like my patients in Houston, Texas. Having their teeth cleaned every 3 months and practicing home care. So there are distinct risk groups in the disease that we treat. So the major risk factors for progression, with tons of evidence: past history of periodontitis, irregular professional maintenance, smoking, diabetes, and genetics. With less information, but still significant: microbial factors, age, socioeconomic status, bleeding on probing. Even less clear, but out there: visceral fat, diet, other chronic inflammatory diseases, epigenetic stress, osteoporosis, and even sleep apnea. But what we know is the negative predictor is more reliable than the positive predictor. Patients without major risk factors are highly unlikely to develop periodontitis. So we know all of this, but can we really use this? Can we make this actionable? We hadn't been too good at that. So if we go back to the beginning of the circle and trying to complete it, so 35 years ago, I was looking at all these basically tooth-related factors. And we've known these risk factors for a long time, but I have not been able to really use them very well. Because I understand them intellectually, and I can counsel my patients on smoking cessation and all those kind of things, but I'm still not being able to connect all the dots. We are now doing a pilot study looking at AI to develop decision support systems that hopefully will allow us to connect those dots. We have de-identified 40,000 of our patients' charts, and we've uploaded these 40,000, this data and others to the AI. And we're in the process right now of training the AI. We're looking at the data, we're analyzing it, we're doing clinical oversights to make sure the AI is thinking correctly, because it doesn't. It's like AI is fancy, but it's still the old computer crap in, crap out. So you've got to look at all of that. We're doing early validation on it. We're confirming there's no missing data sets, and we're allowing the model to make connections that currently are they're unknown or unconnected. And then once we've got the model, we're going to apply it to huge data sets. So AI's strength lies in the ability to analyze vast, complex, multidimensional data sets and identify subtle, nonlinear patterns and interactions that may be missed by conventional methods. And it's obvious that we can't do this on our own, or we would have already done this. It's not a black box, but a transparent co-pilot. It doesn't just tell us the what, the risk score, it tells us the why, giving us actionable intelligence to move that red line toward the green line. You know, I don't think you and I are going to be replaced by AI, but you and I may be replaced by a periodontist who knows how to use AI. So the future role of the periodontist will evolve to include skilled interpretations of these AI-generated insights, ensuring that technology serves as a powerful co-pilot in the delivery of personalized care. But until then, we've got to move beyond the traditional prognostic assessments focused solely on clinical damage to a more holistic approach that integrates a dynamic view of prognosis, formal incorporation of key risk factors into diagnosis, prioritizing and modifiable risk factors as part of therapy, a patient-centered focus on actively addressing compliance, motivation, and behavioral change, and judicious use of existing risk tools and a critical appraisal of emerging AI technologies. So I appreciate everybody being part of this journey, trying to complete this circle over 35 years. We're not there, but I feel pretty excited about the future. So thank you very much for your attention. Look forward to any questions that you may have.
We have time for a few questions, and if you'd like to ask a question, just come forward, please. I do have one quick question for both of you. First, thanks for wonderful presentations. You know, prognosis is really nothing more than a tool that we communicate with our patients, you know, relative to outcome of therapies. And given the advancements in therapies, the advancements in risk assessments, et cetera, all of the things that you've both outlined, is it time that we reframe the term short-term prognosis and to lengthen it to maybe 10 years? Because I think what's happening in periodontics is that when we use the term short-term, nobody wants to save their teeth. You know, they get alarmed by that. And so when we start talking in terms of 10 years, patients seem to be more readily open to having periodontal therapies done. So I'm just curious, with all the data that we have now and all of the advancements, is it reasonable to start to reframe the discussion? Either, I mean, it doesn't either one.
Who are you talking to?
Both of you. Both of you.
Yeah, I think those studies are ongoing right now in terms of just lengthening out the longitudinal studies of all of the different determining factors. You know, can you live with 5 millimeter or greater probing depths? Can you live with, you know, uncontrolled diabetes? You know, all the different factors that seem to be important. But, you know, to do 10-year or greater longitudinal studies that have, you know, valid measurement criteria and so forth, they're not easy to do. They're extraordinarily expensive. And, you know, it's hard to keep a population together for a year sometimes without, you know, paying them and making sure they come back somehow to evaluate different types of therapy. I mean, it's a struggle. To come back for 10 years, 15 years, it's a burden.
Yeah, I agree, and but I'll put a plug for practice-based research. That's one of the big positives of practice-based research, in that the subjects in our studies are patients in our offices, and they hang around, and that allows you to get great long-term data, long-term studies. But also, I, like Dr. Caton, you know, I'm full-time private practice, not quite 50 years, but I'm almost there. And I'm very positive with our patients also. You know, and our practice, while we do implants, we are a traditional periodontal practice. We do, you know, we save teeth. And because we save teeth, you know, I don't know, Brian, where if you're talking about people saying that the short-term prognosis is not good and therefore they're wanting to take out teeth, that's not me. I mean, I'm telling everybody that, and it's the truth, that with appropriate therapy, with the regenerative care, with the maintenance that we can provide, that, you know, we can save your teeth your lifetime. there may be one or two bumps in the road, but I think that prognosis needs to constantly be reappraised at every periodically, based on if things change in their life or after therapy and periodically during maintenance care, all of those kind of things. But I approach it in a very positive way.
Thank you.
Thank you for your presentation. As a clinician, I struggle with the category of hopeless, irrational to treat, especially how I signal that to my referrals. Because we have patients that have, we know that they're comfortable, they're functional, they're aesthetically satisfied with the tooth, but we know it's not going to be there. So we give it a prognosis of hopeless or irrational to treat. Is a better category maybe palliative care to signal to the general dentist not to take this tooth out because we can keep this going? I'm just struggling with that final category.
Well, I think anybody in practice, whether they wanted to keep the tooth or not, a lot of patients will not let the teeth be taken out. And now you're monitoring them every 3 to 6 months for 10 years, and the tooth's still there. It's comfortable. I don't know what if it's infected, it may have an effect on their systemic health, but it doesn't seem to be that measurable. So what you want to call it, I guess, is your own, up to you. I think hopeless is something people could understand. And every periodontist has hopeless teeth that patients want to save, and they're doing their best to help the patient to keep them. I'm quite sure of that. And it's amazing sometimes how long they'll last.
Other questions? Mark?
In response to that, Jackie, like, there are often times we have a patient that has a hopeless tooth that we've been maintaining, and we see effects, not just effects that we can't identify systemically, but locally in the periodontium, we have trouble controlling the inflammation and bacterial factors because it becomes a seed to the other areas of the mouth. When we finally are able to extract that tooth, we see drastic improvements in better ability to maintain the rest of their periodontium. And maybe a comment on that and what your experience has been.
Yeah, I think we all probably agree on the same things, and that is that, when I talk to a patient about a tooth that I, think is probably not going to be there long term, I factor in, is it comfortable, or do they have any symptoms? Is it infected to the state, I don't know if infected is the right word, but let's use that term, to the state that it's going to adversely affect the adjacent teeth? Then that's one of the things that's going to really push me to push them to take it out. And then, as Dr. Caden said, is there going to be an inflammatory burden to their systemic health? But it certainly, is a nidus for bacteria in the mouth. And some of these teeth, as Mark said, when you get these teeth out, all of a sudden, the other teeth are looking better. But we all factor these things in, as we're just thinking about how we're going to go with this.
Tom?
First of all, I want to commend both speakers for an excellent presentation, and I've used both systems for more than a quarter of a century. I'm a traditional periodontist. I had a brick and mortar office just like you did, and our philosophies align, and I understand how the system works, and it worked very well for me. With the dynamic of what's happened over the last quarter of a century with the traveling periodontist, where they go in and they do a procedure and then they leave, how can you have a prognosis system that relates to that type of care?
Yeah, I mean, that's kind of a political question almost. I've always been, actually was in one location for 50 years, same patients, same location. Kind of expanded at the end. I had several partners, so I had to get more locations. But yeah, I think the best part of perio was being able to monitor patients and over long-term and become friends, you know, and be responsible for them over a long period of time. And I got a lot of satisfaction out of that, and I learned a lot. I think if you just do surgery or whatever you do or put an implant in and then go to the next office and never see those patients again, you'll never learn those things. And it would be a very unpleasant way for me to practice. I just don't, that wouldn't be for me. But it is for other people. And, you know, what are you going to do? It's an economic thing. You know, it's a way to make a living. But I don't know.
I'm always an optimistic guy. I'm hopeful that if they are, you know, if they're traveling around, that somebody's still watching them. The hygienists usually, my experience with hygienists is they're people who really like their patients, who are really looking at the best interests of their patients. And I would hope that in those situations, the hygienists come up and be our hero. And in addition to that, you know, whoever's managing the office. But, you know, somebody has to.
Yeah.
Thank you for your lecture. I just have a question about how you frame a poor prognosis for a referring dentist, because I find that when I say poor to a referring dentist, they interpret that as almost extraction. If they got a poor prognosis from an endodontist, they almost think extraction. How do you frame that to referring dentist to be like, it's not in great shape, but it's maintainable? I'm curious to hear how you frame that.
I think you just did it.
That's what, yeah, that's what, you know, you know, that means, I just say it's unlikely that we'll be able to maintain this tooth indefinitely because of certain factors that I can't get rid of, you know, whether it's the probing depth or, you know, whatever furcation or whatever it might be. And, but the patient wants to retain it for as long as possible, and we'll help them do it. Yeah.
Any other questions? Thank you very much.